the robotic systems were quite new, certainly for our teams, and we felt that it took us a while to establish ourselves and establish what we were doing. And we felt that what we needed nationally was a training program for people from all backgrounds to come and to develop their skills and learn. So we've got a brilliant session today. We've got a great faculty. You can talk to them later. We're going to start with the first talk of the day, which is going to be talking about robotic assisted surgery. So those of you who don't know me, I trained in Oxford, so I was there for about 12, 14 years. And then I went to America for a year, Canada for a year. And then I came back to Worcester Royal Hospital, being a consultant there for 18 years, coming up to 19 years. Because I am a high volume surgeon, I do 500 joints a year, which is top 1% in the country. So I've done over 5,000 joints. So the robotic surgery makes you better. It's all about where you want to get to. If you want to stay average or you want to stay in your own little world, you can. But if you want to be the best and you want to get better and you want to do the best for your patients, it will be the future. So my own interest, I started about 6-7 years ago in minimally invasive surgery, which is an interest of me, which was soft tissue preservation and doing operations. And then recently, well, the reason we took on robotic surgery is because we've now got a combination where you protect the soft tissues, you do minimal damage to the tissues, and then you use the robotic technology to position your implant. So we feel that's a world-leading combination. And a lot of the leading surgeons in the world are using these combinations now. So this is our background. I mean, you've got to remember, we started last year and we'd done 0. So we had done none. There were other hospitals that had done 6-7 years experience. We were the first team in Worcestershire, and Spire South Bank brought the robot. We've now done, we're the highest volume single unit users in the UK, and now we've done about 350 joints. So you can achieve that as well with focus and dedication. Now it was a difficult learning curve for us. So we worked with virtually every rep in the country. We had lots of issues in terms of robotic technology, but we worked through them and we can give you our tips and our guidance through that. So first of all, what you have to remember is, let's talk about robotics. So initially in the 1950s or throughout the years, what most surgeons use to plan their surgery is an X-ray. So an X-ray is a 2-dimensional plan, and that's what's still going on. That's what majority of people use. Then navigation came in, and some of you will be familiar with navigation, which systems came in the 1990s. But a lot of those systems were very fiddly. You had to put input into the actual computer. A lot of the data wasn't accurate. I personally wasn't a great fan of navigation because the analogy that I gave patients was that if you buy a new car and you put your home address postcode in and it's taking you around a totally different route, you're not going to follow it, are you? Because you know how to get home. So what happened with the navigation systems of the past is the surgeons were told to follow what the computer said, but they weren't experienced enough to see if there was going to be an error. So when an experienced surgeon is about to do a cut, you can tell if it's totally wrong and you will stop. But if you're not experienced and you're told just follow the navigation and your information's incorrect, then you will cause problems. Navigated power tools came into 2000, and then the robotic assisted surgery. So this is quite a frustrating thing because you speak to a lot of surgeons when you start and they'll say, oh, I'm not sure, it's experimental, we don't know if we should be using a robot. You've got to remember, this technology has been there for 20 years, 24 years. It's not new. The problem is that the hospitals haven't had this technology in the UK until recently, but the technology has been there for a long time. So and funny enough, when I started in Worcester in 2006, in 2007, I was approached, I was met by one of my clinical directors who'd gone off to America, and he brought the chief executive of Mako to meet me. Now, I hadn't heard of Mako then, I didn't know who he was, but the guy said to me, oh, just meet him and tell him you'll use his system. So I said to him, oh no, I can't really, I'm starting in a new hospital, I do the Oxford knee, I can't really change. And I didn't realize, I went over to the American Academy, watched the demonstrations, but 20 years on, that system has now come to the UK. So Stryker acquired the Mako system in 2013. The first Mako hip procedure was done in 2010. And you can see here now, Stryker have put in the software, they've developed the systems, and now the first knee was done in 2016, and 2020 now, we've got new software coming out. So it's evolving all the time. Now, don't let your teams or your hospitals or your surgeons say to you it's new. Because if you look at the actual literature, if you know what you're talking about, there's 18 years of experience on the robotic systems. There's 1.5 million procedures that have been carried out worldwide, and it's available in 43 countries. And there's over 425 papers carried out on the subject. So this is not a new thing that we're telling you. And it will be the future. I mean, if you look at this graph, this shows a chart from 2013 up to 2023, over a 10-year period. And look at the rate at which the robotic technology is increasing in Europe. So we're going from total knees, total hips, and partials. And you can see the numbers, in particular total knees, have just gone up, absolutely exponential growth to really high numbers. So it will come. So the next question is, what is robotic technology? So we need to understand it, because there's a lot of there's a lot of myths out there. So some patients will say, I don't want to be operated on by a robot because I prefer to have a surgeon doing my operation, or the robot might cut the wrong thing, or the robot might cause damage to the back of the knee or the artery. So the surgeon controls the robotic system. The robotic system cannot do the operation by itself. The robotic system has inbuilt safety mechanisms, so in fact it will stop your surgeons from causing more damage, because it will control the cuts. If your surgeon's being rough and ready, reaming too aggressively or cutting too aggressively, it will cut out. It won't allow you to have those problems. So you've got the robotic system, which is known as the Mako, and every hospital has their own name for their own little robot. And then you've got, that's the robotic hardware. Then you've got the applications, which are the software. So at the moment, you can do a total hip, you can do a total knee, and you can do a partial knee. And then you've got the Mako camera stand, and then you've got the don't go near the Mako specialist station, because that's asking for trouble. That's where the MPSs stand, so you can't go near that. You've got to be very careful. They're very protective of their little stations. So I've worked with a lot of Mako specialists over the last year and a half, and one thing we've learned: don't touch their station. That's their little pet. So what do we do? So the theatre setup can evolve and it can change, and we've certainly evolved and changed the way we set up in theatres. But the general principle is, what you're going to have is you're going to have a camera system, which is the one shown on the left. You're going to have the surgeon who controls the robotic arm, which is built-in safety mechanisms. You're going to have to position the patient, and we're going to give you some tips on how to do that. And then you're going to get your data, which is going to be shown on both screens, and one screen is controlled by the Mako specialists. Now, the pathway for robotic surgery is the following. So first of all, we don't believe that you can get accurate information just from an X-ray. So we believe that X-rays are two-dimensional. They only give you a limited amount of information. What you need is a three-dimensional plan in order to determine how you're going to position that joint replacement and what to do. So a CT scan is carried out, and that CT scan will then allow the surgeons and the MPSs to work together to pre-plan the surgery. Before you even start, you'll be able to say to the scrub staff, well, we need a 52 socket, we're going to use this stem, we're going to position it in this position. So all your implants can be checked and available. And then we're going to carry out registration to verify the CT scan during the operation. And then we're going to talk about the technology that's available, which helps you. So let's talk about the knee, because the Mako knee's been on the market for over 7 years. 670,000 cases have been done, and there's 122 papers. But the most interesting thing for me is, because I'm somebody who's a cementless user. So when I started 20 years ago, there was a surgeon in this region called Mr. Holloman who did totally cementless knees. So I went from cemented knees to cementless knees, for about 90% of people. Now, this is the current trend, and I think this trend will come to Britain. So if this is a UK or worldwide trend, 60% of the striker knees are done with Mako. So that's a huge number. And because you can get the cuts accurate now, look, 60% of knees that are Mako knees are done cementless. Now, majority of surgeons are risk averse. They don't want to do cementless knees, and it's more risk averse in America. So to me, the fact that they're going cementless is implying that they're much more confident with the accuracy of the cuts and the balancing. And that, I think, will be the future. Within the next 5 years, you'll see an increase in cementless knees. Now, the problem with the knee replacement is that no matter how well you do one, 20 to 30% of people are not happy. So they come back, they have some pain, they have discomfort, it doesn't feel right, it's a bit stiff, they can't move it. Now, you can have a big major problem if you develop an infection, but most of these problems are arising because the joints aren't balanced. So the surgeons haven't balanced the joint, or the joints aren't aligned. So what happens is, it's not only ourselves. If you look at the literature, this was a paper which looked at 1,700 knees, and 20 to 30% of people were not happy with pain relief or were dissatisfied by function. So there is a problem with knee replacements, and any surgeon who says to you, oh no, all my knees do really well, is either not seeing the patients post-operatively or doesn't understand the issues involved, because most of the literature says. Now, this is my own data. So this shows on the left a plot chart which shows all the surgeons in the UK, and the yellow is my own dot. So, you know, I'm a higher going towards the above average. But again, if you look at the success rates, you know, we're about 75%, 78% success. Satisfaction rates about, if you say good and very good, we're getting, and good, we're getting up to 85%. And if you look at every other surgeon in the UK, you know, they're pretty similar. So even ourselves, we think we're doing well, but we've got satisfaction rates and success rates which are low. So why is that? I'm of the opinion, the problem that we've got is that when you do your knee replacements, all of the knee replacements have an option of 5 degrees valgus, 6 degrees, 7 degrees of valgus. So in other words, whenever you do a knee replacement, what you're doing is you're putting everybody straight. Now, I'm of the opinion that if somebody's been bow-legged all their life and you put them straight, part of the problem is not the joint replacement, but it's the fact that you put them in a position they've not been used to for the rest of their life. So it causes soft tissue pain, it causes balancing pain, and that's where the robotic technology is coming in. So the robotic technology, a bit like a unicompartmental, will allow you to, you know, rather than straighten everybody up, it'll allow you to fine-tune the knee. So you can put the knee into a position which is natural for that patient. So you can look at the anatomy on the other side, you can match it, and okay, they may end up with a bit of bow-leggedness afterwards, but it doesn't matter because that's what they're used to. So in other words, don't put everybody straight, don't put everybody valgus, put them into their own patient-specific anatomy. And what that will do is it will reduce pain. So people, you know, normally you see a knee replacement, we tell them they're in agony for 6 weeks, they'll regret having the operation for 6 weeks, and they'll be on crutches, high painkillers. But as soon as you start to get the alignment better and the balancing better, your results will improve. So how do we do this with the robotic surgery? Well, we know more now than we ever know before. So with the CT scan, we're able to get very accurate, you know, we've essentially got your anatomy. We know exactly what your anatomy is for you. We can compare to the other side. The technology is designed that it will take off the minimal amount of bone needed to balance the knee. And it's quite interesting to us because we do a lot of cases and we've seen that some of these knee replacements, we're taking a fraction of bone off compared to what we do normally with conventional jigs. I mean, you've seen the conventional jigs. You're going to take 8 millimeters off the femur. You're going to take 2 millimeters off the worn side of the tibia, or 9. And that's it. Every surgeon is doing that. But with this technology, we're often reducing the amount of bone loss resection. So the first thing is, once your CT scan has been done, you can make a model of the actual joint and you can plan the surgery. Now that plan It's going to be very specific for you as the patient. So this is before you even start the operation. You get this, so you can look at this with the MPS, and you can look at that, and you can look at the size you want to put on. You can size up the implant. Does it look too big? Is it overhanging? You can fine tune it to get the angles correct. Look at the tibia. Is the tibia the right size? So you're doing all this information before you even start. So the plan will tell you here on the right, it's saying it's a 5 femoral component. It's a 5 tibial component, probably. It's giving you a polyethylene of 9. And it's telling you if your implant's got a notch, if the implant is too big or too small. So that's what you can see, the degree of pre-planning, rather than just looking at an x-ray and saying, oh, it might be a 3, might be a 4, and using the styluses, which are often fiddly. You're getting this degree of accuracy in planning. Then what you've got to do is you've got to try to correlate with what you've got on the table in terms of the patient's knee and the model that has been mapped from the CT scan. So you've got to get the information that you've got on the actual bone into the computer. And that's done by using sensors or tracking devices, which we're going to talk about later on. And then you use probes. There's a blunt probe, which is used for getting key landmarks, such as the malleoli. And then there's a blue probe, which is sharp, which allows you to map the bone. So during the operation, you're going to put the discs on, you're going to get the information from the knee, and you're going to map the anatomy. And so this technology is very accurate. So if you've got a surgeon who's putting the probe everywhere and he's not on the bone, it won't allow you to proceed, because you have to, the model that you're creating during the operation has to be within a fraction of a millimeter of the model of the CT scan. Otherwise, the system will not allow you to proceed. Once you've reached within a certain predetermined amount, the image on the left will come. So it will say, okay, you're ready to proceed. And then you have virtual positions that you can check that you're in an accurate position. And then once you've passed that step, the surgeon and the robotic and the MPSs are confident that we've mapped the anatomy. And then this is the key thing. So will you watch your surgeons do knee replacements? I mean, how do they measure their balancing gap? Because what I see is that most surgeons are just looking at the clock, putting the tourniquet on, and it's all rush, rush, rush. Bit of balancing, put this in, put cement in, it's done. I don't think you can objectively measure what you're doing without the technology. So here you see, this is telling you that your knee's flexed at 90 degrees. It's telling you here what your gaps are. During this surgery, this is the old software, but you want to make sure that your flexion gap and your extension gap are equal. So you can make changes during the operation. See, I'm moving the implant up. You can move it up, you can rotate it. So you can make adjustments so that your flexion extension gaps are accurate. You can see we've downsized the femur there from a 5 to a 4. We've moved it up, and we've got similar gaps now.